In the part one of my lecture, we talked about all the mechanisms of relaxation, and why you have the different signal intensities in the T1 and the T2 weighted images, etc. This today's lecture is a bit of a gathering of sort of loose ends. So we'll jump back and forth between the different topics. I would like to recap a bit on where the signal comes from, and then right after, to finish off that 5-step recipe I introduced on Monday. I'm also going to disclose you a bit how the images build up. I'm not going to tell you in details, and it's not really stuff we're going to ask on the exam, but I didn't say anything about it, and so I'm going to tell you a little bit about it, talking about gradients, etc. And then there is a bit of open ends. I would like to tell you about the contrast imaging and the different sequences, because they probably will be mentioned on Friday as well. So there we go. I showed you this slide in the first lecture. So this is where the sort of the signal arises from, why we need the strong magnetic field, and you have the protons behaving like the compass needles. The strong magnetic field is a serious security hazard. If you Google like MRI accidents, then you will find a lot of hits, topics, images, and maybe also filmed sort of accidents that are like scissors flying in the scanner on purpose. But we have to make sure the machine is operated safely, and therefore we have a lot of precautions like screening of patients with implants, screening of personnel who's going to work at the MRI scanner, and you have to really be careful with ferromagnetic objects like keys or anything in your pocket. You'll always have to take them off. Sounds very seriously hazardous. On the other hand, there's a lot of MRI scanners installed in hospitals worldwide. A lot of scans are being made every day. Apparently, if you do take the right safety precautions and work with it in a safe way, the sort of the hazard is rather limited, and only few accidents have actually been reported in hospitals with MRI scanners. So it is a useful machine that can be operated safely. That's my conclusion. Anyway, so step 2, we apply the radio waves for the excitation pulse. There we go. We do the excitation, and then we have the signal coming out of the patient, and we listen carefully to the signal from the photons. Now we need to know where the signal comes from. So this is a new slide. And therefore I introduce the concept of a gradient. And you could compare it with glasses of wine, if you like wine. And if you have different levels of filling of glasses of wine, maybe you know that you can make a wine glass sing if you sort of wet your finger and put it on the edge of the glass. Now in this case, shown here on the slide, the glasses have different levels of filling, and they will produce a different tone. Now, if I put glasses on the table and I do the filling of them, then I know which position of the glass on the table produces which tone. So if I close my eyes, you sort of hit one of the glasses with your finger, produce a tone, then if my ears work well and my memory works well, I could tell you which position the glass is that you're sort of making the tone with. I can do something very similar in the MRI scanner to encode the position of the signal. Because what I do in the scanner, is switch on a magnetic field gradient. And as we know, the resonance frequency of the protons is directly related to the field strength. And now I have a sort of upslope in my field strength from one end of the scanner to the other, and therefore the resonance frequency of the protons on the one end of the scanner is different from that on the other end. And because I apply the gradient, I define what the gradient strength is, I know exactly what that resonance frequency is at each and every position in the scanner. So this trick is used to encode the spatial position of the signal in the MRI scanner. So what we do here is the slice selection and excitation. So here I sort of visually put on the slide the strength of the gradient. And the way I sort of am showing it is by using different colors. So a different color represents different tonal height if you compare it to wine glasses, or the real world obviously is the different frequencies of the RF excitation pulse. Now what I can do is I sort of switch on the gradient so that you have the different resonance frequencies on the different positions. And in this case, as an example, I apply green radio waves. So they have a frequency, the radio wave frequency matches exactly the resonance frequency of the spins at the green position in the scanner. Now what happens is that only the spins that have exactly the resonance frequency matching with the radio wave frequency respond to that radio wave. They absorb the energy, and the other ones, the different colors of spins, so to say, the spins in another position, they have different resonance frequency and they will not respond to the radio frequency excitation. So the result is that only those green spins will rotate by 90 degrees and the other ones will not. So with this mechanism, I can do the excitation of a selection of spins, and they happen to be in a single slice. Is that clear? Any questions so far? So what happens after I do the excitation? My radio wave is switched off, and then the result is that my slice, the spins in only the single slice have been rotated by 90 degrees, and only those spins will produce a signal. The other spins will not produce a signal. So I've done slice selection. Okay, now the next thing is that I need to do spatial encoding of the other two dimensions, because we live in a three-dimensional world, and I need to encode 3 spatial positions. Okay, so here we have the signal from the spins in that single slice, but I cannot detect where in that slice the signal comes from. So I need to do yet another trick. What I do is I switch on another gradient. And the gradients are actually coils built into the scanner bore. So you have the excitation RF antenna, and you also have 3 sets of gradient coils, for each direction 1. So you have an X gradient coil, a Y gradient coil, and a Z gradient coil. In this case, I switch on the Y gradient coil, which sort of produces a magnetic field that varies along the Y-axis. And so I have the different radio frequencies of the spins. And again, the sort of the frequency of the signal that a compass needle or a spin produces depends on the strength of the magnetic field, which varies in this case along the y-axis. So if you would compare it again to tonal heights, you would have the spins in the different positions, depending on the spatial position, produce different tonal heights. And I can hear them and I can listen, okay, what tonal heights am I hearing and how strong is each tonal height? And then sort of I know how much signal came from each spatial position. And similar with the light colors, you can detect the strength of the color of light. But in our case, it is happening with radio wave frequencies, which we can disentangle. Okay, so while we pick up the signal, while we listen with the antenna, we switch on that gradient, and when we're done sampling the signal, we switch the gradient off again. The switching of the gradient is super fast. It goes in like microseconds. And compared to the field strength, so you have a static field strength of, let's say, 3 Tesla, and then you can have a gradient field of, for example, of 100 millitesla per meter. So that is actually way less strong, but it's still enough to have the different frequencies made detectable. Okay, so we apply, to sum up, we apply a gradient during the excitation, which is slice selection. We apply a gradient during signal reception, which is called frequency encoding. And that is because I encode the spatial position with the frequency of the RF waves. And then somewhere in between, I have another magic trick, which I'm not going to explain because it's too technical. But it's called phase encoding. So I am mentioning the name because it is rather important. And it is rather important because in the end we will need to make up a full MRI image. So we have the slice selection which takes care of one dimension, and we need to encode spatial positions in the image in the 2 dimensions. One dimension is clear, I explained it, it's the frequency encoding, and the other is the phase encoding. Now, in the frequency space, because we are listening to all the different frequencies, so this is an image in the frequency space, and it's called K-space. You have one readout, one time me picking up that signal, switching on the gradient, is one line in that K-space, magical K-space image. And now comes the trick, because the phase encoding is the reason why the MRI scans take so long. Because if I want a, for example, MRI image of 256 by 256 pixels, then I need to do 256 times the phase encoding. So I need to repeat that whole process of, do the slice excitation, do the readout with a magical phase encoding gradient in between, which determines which line I am scanning, and I need to repeat that over and over again. So there also comes sort of an interplay with the spatial encoding and the repetition time and the image contrast, obviously, because I need to repeat my acquisition over and over again to get that full image, get all the information, do the spatial encoding, and I also need the repetition time to create a T1 contrast if I want to have that. So there comes in, the repetition time comes into play. And then what I do is a mathematical trick, which is called Fourier transform, and it basically transforms frequencies into the position. So basically the Fourier transform says how much signal there is for each color of light, and then it puts that into my image. So it sort of disentangles the spatial positions. Then again, this is a rather technical story. The main reason is that the slice encoding is easy for you to understand. The frequency encoding is relatively easy. And I'm mentioning the phase encoding because it explains why the scans take so long. Also, the reason why the MR scanners make so much noise, if you ever heard one scanning, they make a huge noise, like 100 decibel maybe, depending on the scan you're doing. That it happens because you do the fast gradient switching all the time. So you switch on the slice selection, that makes noise. The frequency encoding switches on and off, that makes all the noise. So these are actually the same gradients I'm talking about as Petra mentioned yesterday during the diffusion imaging. So what we need to build an MRI scanner is obviously we need a very strong magnet, and they look generally like this. So it's a metal thingy with lots of wires in there. Then we need a radio frequency coil for transmission of the signal to do the excitation. And the transmit coil is usually built into the scanner there, into the magnet. And the receiving coil, which is the one we pick the tiny bit of signal up from the brain, that's a dedicated coil which is as close as possible to the source of the signal, which is in this case the brain, the head. So it's very tight coil. Then we have the gradient coils, X, Y, and Z, depicted here on the bottom right. It's a kind of a network of all the different coils, and remember we can switch three sets of coils on and off independently in the X, Y, and Z directions to have those three gradient fields in each direction. We need a calculator to do the Fourier transform, which is obviously a super fast computer, not too difficult nowadays. And then we put a nice plastic cover around that whole thing, and we sell it as a clinical scanner that we can install in the hospital. Any questions so far about this part? Okay. So now we're switching back to the contrast, the image contrast, which I think is more relevant for you. And I'm going to introduce yet another metric, which is T2 star. And it's related to something mentioned here, which is two types of sequences. It's called spin echo and gradient echo. So there we go. Just to show you an example, these are MR images of a patient that had an operation of the heart, and then the bone, the chest bone, is tied together with metal wires after the operation. And for some weird reason, I have this sequence called gradient echo, and there's a huge signal drop in that area of the metal wires. And the magical spin echo doesn't have it. It nicely shows the signal in the chest as well. By the way, this is the heart. So you can see the blood is a bit bright in the ventricle, and then the muscle of the heart, the left ventricle wall, is kind of darker. All right. Just another example of the same phenomena. This is a knee with metal in there. And this is spin echo, which does show some artifacts. And this is a gradient echo, and there we have again a huge signal drop. So what's happening there? I'm talking about basically, and the MRI simulator also showed you an option for switching between the two sequences, the gradient echo and the spin echo. Now, the gradient echo actually does show a T2 star contrast, and that is T2 contrast, and T2 is, the tissue property we've been talking about all the time, plus some extra feature, which is local perturbation of the magnetic field. And the first example that I showed, where you have the metal wires, obviously, because of the presence of the metal wires, locally the magnetic field of the scanner is disturbed because it's maybe a bit ferromagnetic, that wire, and then you have a bit of local disturbance there. And apparently the local perturbation of the magnetic field lowers the decay time of the signal, and that's why it's dark. So the amount of T2 star weighting depends on the echo time, just like with the regular T2. And then obviously if you do make a protocol, the repetition time and flip angle will also determine, as normally, the T1 weighting. Now, on the other hand, we have this magical spin echo sequence, and that includes a method to refocus the macroscopical dephasing. So the spins are sort of, made into chaos by the presence of the local disturbance of the magnetic field, and the spin echo has a trick to refocus it. And only the spin echo, and that's something to remember, spin echo can provide the real T2 tissue contrast. So if you want a T2 weighted image, you always need a spin echo sequence. Okay, so what is it useful then for the gradient echo? And this is one of the few examples where the T2 star contrast is actually used in the clinic. In case of microbleeds, and then you see all the tiny bit, the black spots, the small black spots there with the arrows, there, and those are microbleeds, so a tiny bit of bleeding in the brain. Could you guess what sort of locally disturbs the magnetic, the homogeneity of the magnetic field there? Because you have a similar signal drop, although it's a tiny spot. It's a very similar signal drop to the sternal wire we showed in the first slide. But now it's very localized. There's no bits and pieces of wire there. There's no sort of metal, I would say. But what in case of a microbleed, what would be the source of the perturbation of the local field? What could that be? Hemoglobin, yeah. So it can have two states, like bound or not bound, and there's iron in there, and that's the essential thing. And then in the chemical substance, that sort of when it bleeds out of the vessel, when there's a bleeding, the chemical structure changes, and the iron becomes ferromagnetic, a bit more ferromagnetic than when it's bound into the red blood cells. And obviously there's a high concentration there of iron. And that makes a local disturbance, and that makes you able, that phenomena allows you to make the microbleedings visible on MRI. On the spin echo sequence, which is T2 weighted, you will not see the microbleeds. It will just not be visible at all. So that's interesting. And there's another purpose, because even if the signal is within the blood vessels, the iron also disturbs the field homogeneity a little bit. So if you make the echo time long enough, you can also make the blood vessels, the veins, visible. And recently, a new guideline was introduced for the diagnosis of MS. And it's called the central vein sign detection, which basically says that in MS, in an MS lesion, there's always a vein in the running centrally through that lesion. So if you can actually see the presence of a vein in a lesion, you know that it is, or it confirms that it is MS. If there's no central vein, it might be some other lesion. So here again, I have a T2 star weighted image, which is also called susceptibility weighted image, SWI. And you can see the vein there. It's a dark stripe because of the local disturbance of the magnetic field. You have a shorter T2 star, which makes it dark on a T2 star weighted image, just like with T2. And then you can also see that lesion also shows a bit of contrast. It's a bit brighter, but to confirm it's really a lesion, we use the flare image. So we put them side by side. We make the images, the slices identical. And if we put them side by side, we could even merge them if we like. Then you can clearly have the lesion visualized on the flare image and the veins visualized on the T2 star weighted image. Here's another example, which is a bit of an exotic example, I should say. And then there was a cohort of patients scanned in the US. The reference is there. No, it was not by the names of it. It was in Holland. So anyway, but the patients, the group of patients, showed these black spots on gradient echo images, whereas on spin echo images they were not seen, which suggests again its presence of metal. Now you could probably not guess what happened there, but it was really weird that all these patients had a certain type of heart valve. And the heart valve actually also contains metal. And apparently the construction of that heart valve was a bit weakish because you have the blades of the heart valve, the mechanical motion happening all the time. And apparently the metal got tired and broke off. So there was a tiny bit of metal that broke, got into the circulation, and well, it's pumped around, and then it got stuck in the brain in a tiny vessel, and it was detectable by the gradient echo. So that's how they found out these heart valves actually have a mechanical issue, and by now they will all have been replaced because this publication was some time ago. But it does show a sort of a weird example that you can detect metal with the gradient echo sequence. Any questions so far about gradient echo T2 star images? I'm just showing some images. Just a remark about the gradient echo sequence. It is used a lot, also in the clinical daily use, but then mostly it's used with a really short echo time, and the gradient echo is fast, so you do the excitation and you read the signal right after. Spin echo takes a bit of a longer time because you need some additional tricks, but if you have a really short echo time, it doesn't have the T2 star weighting, and that means you can use it for T1 contrast, because you can do a rather short repetition time if you like, or you can combine it with an inversion pulse to create T1 contrast or whatever. But the gradient echo is not only used for T2 star imaging, but also for T1 imaging with a very short echo time. And then again, if you want T2 contrast, you really need a spin echo. All right. So I think I owe you another clinical example that will highly likely be presented by on Friday in the clinical cases, and that is the Neuro perfusion, and it's using dynamic scanning of the injection of a contrast agent. So what we do is we do super fast scanning, and that is done with echoplanar imaging. And echoplanar imaging is meaning it's a trick where you do one excitation pulse and then you read all the phase encoding steps at once. Super fast. You can scan the whole brain in 1 or 2 seconds, but the image quality is sort of poor. So it's not really suitable for diagnosis. You can't see any anatomical details. The voxel sizes are large. It's a bit blurry, but you use it in this case because you want to really scan fast. Because what happens is that you inject the contrast agent. It passes through the lung circulation and through the heart, and then passes through the brain. And you scan so fast to see the contrast agent passing through the vessels in the brain. So it's called the first pass. And then what you do is the EPI you combine with a gradient echo technique, so it's T2 star weighted, and you have a bit of a longer echo time, 30 milliseconds. So it really you use the T2 star weighting in this sequence because the contrast agent also highly reduces the T2 star. So the presence of the contrast agent makes the T2 star really short. And then because you scan so fast, and you scan the whole brain really fast, you sort of get a time series. And that's depicted in this curve. So if you take the signal in one voxels or in a group of voxels, if you make a small region of interest, and you can do for each temporal phase that you scan, you can sort of quantify that signal in that voxel and put it in a time plot. So on this plot, we have vertically, we have the signal strength, and horizontally, we have the time axis. Now, what you see here is at first nothing seems to happen because that is we started scanning before we injected the contrast agent. So then the signal obviously should be constant. And the real world measured signal is sort of the noisy signal there. It's in one single pixel. And then the other one is the fitted curve. So we're looking now at sort of the really measured signal. And you see at a certain point in time it drops. And the drop in signal because it drops in signal because at that point in time the contrast agent arrives in the brain, in the blood vessels, and it passes through. And because the contrast agent reduces the T2 star, the signal in this T2 star weighted sequence goes down. So it goes down, and then the contrast agent passes. So the signal goes back up. You have a question? Sorry, how? Oh, okay. Yeah, so how does the contrast agent reduce the T2 star signal? That is because so it is a gadolinium based. The contrast agent is basically the gadolinium with the sort of the shell around it that makes it non-toxic. And the gadolinium interacts with the protons around it. It also disturbs the local magnetic field a bit. So the contrast agent lowers the T21 of the tissue around it, of the water around it. It shortens the T2, and it also shortens T2 star. And the T2 star reduction is rather strong because it has a sort of double interaction, also disturbing the local magnetic field. That was actually in my slide on the first presentation, the last bit. So I'm not, but you don't really have to understand the mechanism, but it's good enough if you just know that the presence of contrast agent reduces T2, T1, T2, and T2 star. And we're not looking at the contrast agent itself. We're not getting signal from the gadolinium. We're still getting the signal from the water surrounding the gadolinium. Okay, so we have this curve. And then what is happening quite often is that you fit a sort of parameterized curve to the measured one to get a sort of a more smooth solution. It turns out that if you do a mathematical modeling and calculation, that the area, I would say the area above the curve. Usually you have a curve which is sort of upside down, then it would be the area under the curve, but now it's above the curve. So you have this sort of triangle here with the curve going down, and then here you have the sort of the baseline. If you think of that as a sort of dotted line extending it, this here, this area is important because it sort of estimates the blood volume in a voxel. So it's called the cerebral blood volume, CBV. Because it's a surface in this curve that you estimate, it's rather robust. It's not very sensitive to noise, and it works pretty well also in clinical practice. And you can do that for every voxel, and then you can make this map here, where the color of every voxel shows the area of that above that curve, or otherwise formulated, this is a map of the cerebral blood volume in each pixel. And that means you can do, here you can see a perfusion defect in this area in the brain. There's no blood present. So this is a serious issue for that patient. You can also see there's some hot spots, which are probably larger veins, larger arteries supplying the blood. And in tumors in our hospital, we mostly use this technique for tumor staging, because the tumor aggressiveness is highly characterized by the blood volume that's present in that tumor. And you can quantify that with the CBV measurement. So it's mostly used in oncology. And in oncology, most patients get a contrast agent administration anyway, because the tumors are sort of really nicely highlighted on T1 weighted imaging. And because you administer the contrast agent, you sort of get, if you run the scanner with this dynamic sequence during administration of the contrast, you kind of get this information for free. It doesn't cost you any additional time. You just have to start the scanner with this scan during administration of the contrast agent, which you will do anyway. So it's, again, it's sort of additional information that is in some cases useful and in some cases it's not, but you know, doesn't cost you anything extra. Okay, so just to give you an idea, this is a listing of a clinical protocol we would run on the scanner for a neuro-onco patient. So we start off with a localizer, which is similar to what you've seen in the simulator. You get a very quick scan of the brain, which doesn't show much anatomical detail. Usually it's in sort of three directions, and you can use that to navigate and position the other slices, the slices of the other series. So a typical neuro-onco exam would include a 3D flare with the dark CSF. That would be about 6 minutes, maybe a bit shorter. And then we have a T1 weighted triple spin echo. So that has typically short echo time, obviously, and a repetition time in the order of magnitude of the T1 of the tissue. And that would be around 4 minutes. We do diffusion weighted imaging, which you have already had the lecture about, so ignore that remark. Then we have the T2 weighted fast spin echo, which has a longer echo time, a longer repetition time. Then you would do the dynamic contrast scan while administration of the contrast agent, and you get the CBV map. And then you would typically do T1 weighted scanning after the contrast agent was administered to have a scan which is T1 weighted that does show the tumor highlighting where the contrast agent leaks out of the vessels. And then you repeat that scan which we did earlier, the T1 weighted fast spin echo. So you have one reference without the contrast agent and one with. You could do image subtraction if you like, and then only the areas which have changed in signal intensity, which have absorbed the contrast agent, will show up. So it shows you the signal enhancement due to the presence of the contrast agent. Well, this is kind of a summary of everything I told you in these lectures. Told you a lot of the tissue about the tissue properties. And there's a lot of other stuff I didn't tell you that does exist. You know something about the machine settings that we can do, difference between the result of the resulting image of spin echo and gradient echo. I told you something about magnetization preparation pulses, and then the use of contrast agent and some examples of that. And then my last slide actually is similar to the first one that I showed. And basically, I guess you sort of roughly get an idea now why the MRI image doesn't exist. But you know something about, the settings, the tuning of the scanner, how you can get the different contrasts. And you can also imagine there's more settings you can do on the scanner, getting more different kind of contrasts and clinical applications. And they, even nowadays, new applications even are in research emerging. So there's continuously development there. It's complex, but I think it's really interesting and very powerful. Okay, thank you.